Hello and welcome back. Today we're going to talk a little bit about the pathophysiology of some common female reproductive disorders. I can't cover everything about everything, but these are some exemplars, and some of these are quite complex, but my goal is to just get you familiar with general patho, um, clinical manifestations, treatment, screening, and that kind of thing. If you're curious about any of it, dive into your textbook, look up some additional resources. But let's go ahead and get started with PCOS. So, PCOS stands for polycystic ovarian syndrome. This lovely little black and white picture is a picture of an ultrasound of an ovary. And so those little black black circles there are what we would call the cysts in polycystic ovarian syndrome. Now, I would bet that some of you listening have had or know someone who has had an ovarian cyst where it caused abdominal pain, maybe it ruptured. That is something different than PCOS. So, the cysts in PCOS are actually like little ovarian follicles that we're going to talk about in a minute. They're not a true cyst, but that's what they look like on ultrasound. So PCOS, it is a hormonal disorder. It happens to females of reproductive age, so it can have an onset in early puberty, but it can happen at any time in a female's life. Give if she's of reproductive age. Uh, and it is characterized by irregular or absent ovulation, excess androgen levels, so excess testosterone. All women have a little testosterone, but this is excessive. And polycystic appearing ovaries on ultrasound. So just like this picture shows. So the polycystic, in the name polycystic ovarian syndrome, it's talking about having immature follicles in the ovaries. So if we go back to our last lecture and we remember how follicle stimulating hormone and luteinizing hormone and really everything works together to develop these little sacs, these follicles with eggs for ovulation, that is a process that is not going right in PCOS. So they are kind of getting developed, but not adequately. So this is kind of where the problem starts. So this is a mixture of reproductive problems, metabolic problems, and endocrine problems. And it's extremely common. It's about 1 in 10 females that are affected, and it is the number one cause of infertility. Um, I'm trying to stay pretty neutral when I talk about this, but one theme that you're going to notice when we talk about alterations of female reproductive of the reproductive system is a lot of these things have not been properly studied, not the way that certain other disease processes have been studied. Um, and a lot of their origins are mysterious. We are just now starting to see PCOS for the full implications it really has. I have heard some clinicians I respect kind of refer to PCOS as like diabetes of the female reproductive system, which is like maybe a little more complicated than we need to get into. But it's truly a syndrome that it doesn't just cause problems with your period, as a lot of people like to think. It's linked to insulin resistance, it's linked to obesity, and increased risk for type 2 diabetes and cardiovascular disease, which, if we can remember back to our um, little modules we did on obesity and kind of like the interconnected problems with that, metabolic syndrome has some really big implications. So, let's talk a bit more about it. It's a condition of excess androgen production from the ovaries. We don't know what it's caused by. We think that there is likely a genetic link to this. Um, what is going on is anovulation, and that term, whenever you see that little prefix an, that means like absent. So absent ovulation occurs because um, there's no good follicular maturation. And so what happens is that the ovaries just get distended and have all these little cysts on them. And there's a relationship between the high androgen levels and the insulin resistance that happens. And to go back to that diabetes module that we did, we know that insulin itself is a hormone. Insulin resistance is, well, let's go back for another minute. The purpose of insulin is to carry sugar, fuel into the cells. So insulin resistance kind of happens when those cells are not opening the door for that insulin to carry the sugar in. Um, what happens when you have insulin resistance? Well, insulin is really good. If it can't get into those cells, it's going to find there's an unlimited amount of space by depositing in adipose tissue. So it can just make more and more and more fat. And adipose tissue itself has an endocrine function and it affects hormones. So it's kind of this circular problem. Um, so the pathophysiology is we have too much luteinizing hormone. So remember, luteinizing hormone triggers the release of the egg, but it also stimulates production of androgens. And the pituitary gland doesn't make enough follicle stimulating hormone. So the high luteinizing hormone is like asking the ovaries to pump out a bunch of testosterone. Because the follicle stimulating hormone is low at the same time, the follicles don't mature, and so that means that ovulation doesn't happen or it rarely happens. And then all those little immature follicles pile up, and that creates that polycystic appearance on the ultrasound. So I said we don't really know the cause. It could be genetic. There's also talk of environmental factors. And the only prerequisite as far as timing goes is it can happen at any time beyond puberty. I know several people with this, and a lot of them, it started as young as 12 or 13. So the clinical manifestations of PCOS is irregular menses. Now, when a girl first menstruates, it is normal. It's normal for it to take up to 3 years after a girl first gets her period for that period to become regular. So, say a girl gets her first period when she's 12 and she's having cycles that, she's like skipping them, and one is 28 days long and another is like 38 days long. That's considered that wouldn't necessarily raise an eyebrow with a clinician up until she's 15. But if it's persisting beyond that, then that is irregular menses. Remember in our last lecture, we talked about, this like the menstrual cycle where um, ovulation is the trigger that ovulation and lack of fertilization of that released egg is the trigger to make the hormonal changes that makes that endometrial lining break down, that makes someone have a period. So if somebody isn't getting a regular period, then we need to question, do they have PCOS? Um, we also see something called hirsutism, which means hair, where a female wouldn't normally have hair, so could have hair on the face, acne, and obesity. And the cause of that hirsutism and the acne is that additional testosterone. So, testosterone obviously is what produces facial hair in males. Um, Acne gets worse with testosterone because it makes our sebaceous glands in our skin produce more oil. So you'll see an increase in acne. And then higher insulin levels, like I said, lead to more fat storage, especially around the abdomen. And that can also make it harder to burn off fat. Um, that extra androgen also disrupts the metabolism. Also, if we remember back to that obesity lecture, PCOS affects the hunger hormones like ghrelin and leptin. So those control how full or how hungry we feel. So it can even like make somebody with PCOS crave the sweets and carbs more often. And one of the big things is, like I said, PCOS is like the number one cause of infertility. So, this collection of symptoms would really make it likely that somebody had PCOS. So, in fact, we use something called the Rotterdam criteria along with labs and an ultrasound to diagnose PCOS. So, here's the Rotterdam criteria. Two of the following three are required. So, oligo or anovulation. So, that could be inferred with irregular cycles. They can also test to see the luteinizing hormone levels. If somebody is in the FSH levels, if somebody is experiencing ovulation, they should be experiencing a spike that is like out of line with its level the rest of the cycle. But if it's persistently elevated and they have hyperandrogenism, so an elevated testosterone level or polycystic ovaries on ultrasound, that could be enough to get diagnosed with PCOS. Now, there are some other things that could mimic PCOS, like adrenal hyperplasia, if somebody had a tumor that was secreting an androgen, Cushing syndrome. So, if this diagnosis is suspected, they should be checking for those other things as well. As far as treatment goes, there's a couple options. There's a combination. So, weight loss is one of them. Now, this can be very frustrating for a female with PCOS when she's told to lose weight because, as we kind of discussed, she's experiencing some hormonal changes that make that a little more difficult than just a calorie in, calorie out protocol. Um, they're likely going to need some additional help being on metformin. If you can kind of remember back to our diabetes lecture, metformin is a first line treatment for type 2 diabetes, but it also helps with insulin resistance. So it's going to help those cells open um, to the insulin and decrease that insulin resistance. And spironolactone is another one that they prescribe to combat that testosterone, that elevated testosterone. And spironolactone, um, it is a diuretic, so it will make people pee, but it's prescribed in a low amount. So it's very common to see people with PCOS on metformin, spironolactone. Um, and OCPs, oral contraceptives, sometimes will be prescribed to try and help like regulate a menstrual cycle. But um, an interesting thing is there's different degrees of PCOS. I have personally known people diagnosed with PCOS who were on oral contraceptives for years, so taking birth control pills, were put on them very, very young, and then kind of got lax with taking them, and simultaneously were on like they just happened to be on Weight Watchers. I'm not promoting that in any way. I'm just saying what this person was on. So they were like doing some intensive diet and exercise and happened to lose a lot of weight, such that she actually started ovulating again. And that coincided with being off the oral contraceptive. So one thing led to another. And this friend of mine ended up being 25 weeks into her pregnancy before she realized that she was pregnant, just because she had always been told that she couldn't have children because she had PCOS. So it can happen. So just if you know anyone like that, be aware. It's not written in stone that you won't be able to have kids if you have PCOS. There are lifestyle things you can do. Okay, so moving on to endometriosis. So, endometriosis is a disease when tissue that normally is inside the uterus, so that endometrial lining, grows outside the uterus. Now, that is typically going to be um, on the ovaries, fallopian tubes, bowels, or pelvic lining. So usually it's in those organs of the abdominal cavity. Not always. It can, endometrial tissue and endometriosis can deposit literally anywhere in the body. It's not super common, but it's also something like the symptoms are pretty vague when it does happen. And, frankly, when I've seen that happen, women have just been dismissed for a long time or had these written off as psychosomatic symptoms. But I have seen cases where people had endometrial tissue on their heart, on their lungs, kidneys, etc. So the problem is that when this endometrial tissue starts growing outside the uterus, it still responds to monthly hormones. So it still thickens, it still breaks down, and it still bleeds with the menstrual cycle. So there's this cyclical pain that occurs anywhere that endometrial tissue has deposited. So this can happen at any age, but it most commonly happens between ages 25 to 40. So there's some different thoughts on what is happening with endometriosis. We still don't know. I'm going to go through the retrograde menstruation theory, but some other theories include genetics, include stem cell. The stem cell is the idea that like stem cells migrate to other areas and differentiate into endometrial tissue and environmental. And then there's even a theory that immune dysfunction causes this. But I'm going to go with retrograde menstruation. So basically, the retrograde menstruation theory is that during a woman's period, instead of all the blood going out through the cervix and the vagina like it normally should, that some of it flows backwards through the fallopian tubes into the pelvic cavity. And then this backward flow carries endometrial cells which stick to nearby organs and start growing there. And then during the implantation and growth phase, the misplaced endometrial cells attach to surfaces like the ovaries, the bladder, the intestines, or the pelvic walls. And they just invade and they grow like normal endometrial tissue would grow inside the uterus. And then when estrogen and progesterone do their thing every month, those cells start to thicken and break down and bleed. But that blood has no way to exit the body because it's not leading out of the cervix. So then what happens is that trapped blood and that repeated bleeding cycle causes inflammation and irritation. And then you get fibrosis, which is scar tissue. You get adhesions, which is organs sticking together. We get what are nicknamed chocolate cyst endometriomas on the ovaries that are filled with old blood. And that trap blood and repeated bleeding just further that inflammation and irritation. So then we get hormonal involvement. Um, Endometriotic tissue grows and becomes active in response to the estrogen. And then we have progesterone resistance. So remember, progesterone's function is normally to calm things down, but the cells stop responding to progesterone. And so inflammation and growth just keeps occurring. So it's a very, very painful thing. So pelvic pain, dysmenorrhea, and infertility are the primary symptoms of that. And just anecdotally, I can say that it's a very long road to diagnosis with endometriosis. Um, they can do diagnostics. They can do a transvaginal ultrasound where they put a probe up the vagina and they can see the ovaries, they can see the uterus, they can see those structures. So if there happens to be the endometrial tissue deposits there, they will see it. MRI can be helpful, but the definitive diagnosis is a laparoscopy. And during a laparoscopy, they would be inserting a small camera in the abdomen, and they can directly visualize those endometrial implants, cysts, or adhesion. And then they can biopsy, sometimes to confirm the diagnosis under a microscope. So you can imagine if the endometrial tissue has deposited somewhere outside the abdominal cavity, it can be pretty hard for them to find. And once again, anecdotally speaking, even the decision to undergo an abdominal surgery is not one to be taken lightly, and convincing someone, convincing a provider to do an abdominal surgery is not always an easy task. So there's no cure for this. I want to highlight that first off. Even if a woman has her uterus and her ovaries completely removed, um, the endometrial tissue deposits, if they're outside of those organs, they're still going to remain and they're still going to be subject to those hormones. So, usually, like a complete hysterectomy, there's relief, but it's not a 100% fix. What they will do is they will treat with hormones, so try to balance that, balance that estrogen progesterone effect. NSAIDs, if it's particularly bad, might even need something stronger than NSAIDs, and like I said, surgery. But once again, there is no cure for this. Okay, moving on to ovarian cancer. Um, Ovarian cancer originates in the ovaries, as you might guess, and it is one of the most common gynecological cancers, and it affects women of all ages, but it's more prevalent in postmenopausal women. So, ovarian cancer starts when normal cells in the ovary mutate and they start growing uncontrollably. And then those abnormal cells, they start to ignore normal signals that tell them to stop dividing or to die, known as apoptosis. And then over time, they form a mass that can invade other nearby tissues and spread to other organs in the abdomen and even beyond that. So most ovarian cancers start in the epithelial cells, which is the thin layer of tissue that covers the ovaries or the lining of the fallopian tube. And then there are three main types of um there's three main types of ovarian cancer, and it's all based on where those cancer cells originate. So 90% of them are going to be um epithelial, so the surface epithelium of the ovary, like I said. And unfortunately, this kind is usually detected late. So that's one of the reasons that ovarian cancer is one of the Um, it has one of the highest mortality rates of cancers, not because it's particularly hard to treat, it's just that usually it doesn't get detected until much later. 5% are germ cell tumors. So those originate in germ cells, and that is usually found in younger women. And stromal is the other 5%. This is in the hormone producing connective tissue, and those might secrete estrogen or androgens. So the disease process of um, ovarian cancer looks like we start with the genetic mutation. So we have DNA damage or mutations in genes like BRCA1, BRCA2, or P53, and that impairs the cell's ability to regulate growth. And so those mutations can be inherited or they can be acquired. So some of you may be familiar with that if you have a female relative or a mom who is BRCA positive herself. If you have a family history of ovarian cancer and or breast cancer, I would recommend considering getting tested for BRCA1 and BRCA2 because there are people who have that genetic testing done, and then based on the results, they might decide to have um, their ovaries removed and or total mastectomy to prevent that. So just something to consider. So it could be inherited or it could be acquired through damage we acquire to our DNA throughout life. But we have the uncontrolled cell growth that leads to the formation of the malignant tumor. Um, this the ovary when there is spread, it spreads within the peritoneal cavity first, and cancer cells implant on those nearby organs. So they would implant first on the uterus, bowel, bladder, and peritoneum. And then we have something called peritoneal seeding. um, the tumor cells that are in there start to shed into the abdominal cavity, and that's known as the peritoneal seeding. And then the cells irritate the peritoneal lining, and that's known as inflammation and fluid buildup. So that causes ascites. Um, Metastasis occurs, that's the name for when the cancer spreads to other organs. So, like I said, it can be direct extension to the pelvic organs. It can spread throughout the lymphatic system through the pelvic and para-aortic lymph nodes. And then it can also spread through the bloodstream to places like the liver, the lungs, and the pleura. So you'll hear people say like ovarian cancer with Mets to the liver, Mets to the lung. Um, yeah. So how this is diagnosed. So unfortunately, there's no screening for ovarian cancer like there is for breast cancer or cervical cancer, which we're going to discuss cervical cancer. The reasons as to why, not something I'm going to really get into in this lecture. I encourage you to look it up, but basically, they've never found that screening for ovarian cancer seems to yield good results. Sometimes with these things, like researchers put their heads together and decide that it could lead to perhaps like overdiagnosis, maybe diagnosing things that wouldn't necessarily be a problem. But anyway, I digress. What should be occurring when females, as part of like just general screening, people say pap smears, and what a pap smear is a very specific kind of diagnostic test to screen for cervical cancer. But what happens when you're getting that pap smear is also a pelvic exam. So a practitioner should be doing a pelvic exam, and when they are using their fingers to uh, basically palpate the uterus, and they should be trying to feel the ovaries as well. Now, that can be pretty difficult, but sometimes, like a mass is felt on that pelvic exam, which is just a hands-on exam. If that is suspected, they can also do a CA 125 blood test, which is not a 100% definitive, but can give some clues as to what is going on. Um, so then, if it's suspicious, they would refer someone for a transvaginal ultrasound, which is first line imaging. You can see there that it can detect an ovarian mass or cyst, and it can evaluate the size, shape, and the internal features. Is it solid? Is it cystic? And you can kind of see those other diagnostic tests. So, what would make somebody think outside of having um, maybe a mass on pelvic exam that they had ovarian cancer? Well, kind of the scary thing about it is the symptoms are pretty vague. Abdominal distension and bloating. So, you know, I I can say a lot of females experience abdominal distension and bloating just from, maybe eating a high salt diet and just as a regular part of a menstrual cycle. Women tend to retain a little water during their menstrual period. Early satiety, so that's a big one, is feeling full pretty soon, and nausea. But typically, the cases I've seen with all of these things, um, it's not so pronounced usually that people are going to the emergency department for it. I have seen ovarian cancer found as a result of like looking for something else, but so you can see there are these vague symptoms. So if somebody's having these vague symptoms, which honestly at any given time, like pick one of these, and a lot of women could say they're experiencing them. Uh, but that in conjunction with an abnormal pelvic exam, they should be getting a transvaginal ultrasound. So treatment and prognosis. So treatment's going to be chemo and radiation, possibly surgery. If this is caught when it's stage one, which means that the disease is confined to the ovaries, there's a pretty good survival rate. So 90% at 5 years. And I think all cancer survival rates kind of go by that 5 year earmark. Um, Stage two means that it has spread to nearby structures, so the fallopian tubes of the uterus. Sadly, most ovarian cancer, it just isn't detected until later stages when it has a poor survival rate. So if it's stage four, which means it's mets to organs outside of the nearby structures, there's a less than 15% survival rate. Okay, cervical cancer. So remember, the cervix is the bottom of the uterus. It is that part that protrudes into the vaginal vault. And you can see there's that picture of cancerous tissue. So cervical cancer is a malignant tumor that develops in the cells of the cervix. And the most common part for it to begin is in what's called the transformation zone. So that is the area where the squamous cells of the outer cervix meet the glandular cells of the inner canal. So if you've ever had the delight of going through a pap smear where they take their little tool and they grab a sample, that is that zone that they are aiming for. I know it's lovely to think about. The average age of diagnosis is 50, but the most common age range for new cases is 35 to 40. So, a little bit on the pathophysiology. The starting point is an HPV infection, so human papilloma virus. And there are many, many, many varieties of HPV. The problematic ones, the most problematic ones anyway, for cervical cancer are type 16 and 18. So HPV spreads through sexual contact and it infects the basal epithelial cells of the cervix in that transformation zone, especially. And then once the HPV enters the cervical cells, it releases DNA of that virus that becomes integrated into the host cell's DNA. So that triggers production of these viral proteins, E6 and E7, which interfere with the cell's normal control mechanisms. E6 protein blocks P53, which is a tumor suppressor gene, which is responsible for detecting DNA damage and triggering cell death. So that protein isn't allowing P53 to do its job. So these dysfunctional cells can just keep on hanging around. And then the E7 protein does something similar with the retinoblasta protein. So the end point is that we have these cells hanging around that are not functional anymore. And those abnormal cells just start dividing and accumulating more and more mutations. So over time, and this can take quite a bit of time, the abnormal cells form precancerous changes in the cervical epithelium, which is known as cervical intraepithelial neoplasia or squamous intraepithelial lesions. And there are different grades of CIN, as we would call them, from mild dysplasia, which can just go away on their own, to grades 2 and 3, which are moderate to severe, which represent a higher risk of progression to cancer. So, a little sidebar on this. I'm old enough that I have lived through the changes in screening. It used to be that they recommended women get screened for cervical cancer like basically every single year once they were sexually active. Um, and then they figure out that now I think that there's some conflicting guidance, but no one is recommending annual anymore unless you fall into a special category. Now they revised it to be about every 5 years because for certain age groups, because if you're young, the thinking is that your body has enough protective mechanisms that oftentimes these dysfunctional cells and these changes will be taken care of by your body's protective mechanisms. Um, and that it was putting women through like a lot more duress and invasive procedures to be screened so aggressively. But screening still is super important. So if a high risk HPV infection persists, that can progress to an invasive cancer. So if that is not detected or treated, the cells will just continue to mutate and they'll invade deeper and deeper layers of the cervix, known as an invasive cervical carcinoma. And then that can spread to the uterus, the vagina, the bladder, the rectum, then the lymph nodes, then distant organs like the lung, liver, and bone. And here's just a little table of some cervical cancer screenings. So, we have the pap smear, which I'm not going to say that long word that it's pap smear is a nickname for, but the purpose of a pap smear is to detect abnormal cervical cells. And that sample is taken from the cervix during the pelvic exam. And it identifies dysplasia or early cancer, and it should start at age 21 for most women. There's also the HPV DNA test, and that is useful for detecting high risk HPV types like 16 or 18. It can be done alone, but it's most often done in conjunction with the pap smear, so that is known as co-testing. And that is really only used for women greater than 30 years old if the pap results are abnormal. So it's not generally useful to be used with men as a screening tool. There are certain times like you would do that, the HPV test DNA test on a man, but not really for reasons we're going to cover in this lecture. So, how does cervical cancer manifest? Um, Sometimes, like a lot of the times, like cervical cancer is found because of these screenings, like the pap tests. But abnormal bleeding can also be a sign. Um, Out of the ordinary discharge can be a sign. Um, Abdominal pain can be a sign. If a woman is experiencing abnormal bleeding, fluctuations do go on in the menstrual cycle. And, just as another little side note, um, stress and just changes in environment have a lot to do with menstrual irregularities, because basically, a woman's body always wants to reproduce. The body itself is always going to try to achieve a healthy pregnancy. So it's common in times of stress that women will not ovulate, and that's not necessarily part of any disease process. That's a protective mechanism on the body's part to prevent a miscarriage. Now, not always, like there are some women who will just ovulate kind of no matter how much emotional or environmental stress they're going through. But it is pretty common during times of stress for women to experience missed periods or lengthy cycles. But if somebody is experiencing abnormal bleeding, they should probably get it checked out sooner than later because this can be a sign of cervical cancer. Now, we have HPV vaccines, which I'll discuss a little bit more on the next slide. That is to prevent the most problematic strains of HPV that are linked with cancer. Cervical cancer is diagnosed through, first of all, the pap, and then if we find abnormal cells, there will be a biopsy. There is something called the LEAP procedure, in which a thin wire loop is heated with a low voltage electrical current. They can use this to cut away abnormal cervical cells, and then they remove that tissue and it's sent to a lab for biopsy to confirm the diagnosis and ensure that all the abnormal cells were removed. So generally, cervical cancer has a pretty good prognosis if it's caught in the early stages, which, thanks to these screening procedures, it usually is. Um, but it's really crucial that it be confined to the cervix. Um, Moving on to HPV vaccines. So this is a preventative. I do also want to say that if somebody does have cervical cancer, they will be treated with chemo and radiation. But one of the really big important things with cervical cancer is lifestyle, specifically not smoking. Tobacco smoking is really linked with cervical cancer. Um, Inhaling all of those chemicals and toxins is going to just turbo boost that abnormal cell reproduction. So it's very important that if a woman is diagnosed with cervical cancer and she smokes, she needs to stop. And try to live a generally healthful lifestyle otherwise, but there's a huge link between tobacco smoking and cervical cancer. HPV vaccines. So Gardasil's one that you may have heard of. Maybe a lot of you got it. It protects against 9 HPV types, so you can see 16 and 18 in there, along with all these other ones. It's very widely used today, and it prevents both cancer and genital warts. Now, Gardasil is routinely given between ages 9 to 12 years old. And the reason for that age range is because the thought is that we need to target people before they've had sexual exposure, because um, you can be exposed to HPV the first time that you engage in sexual activity. And then there is a link with cervical cancer and Like the earlier you start engaging in sexual activity, the more likely it is that you could have cervical cancer. And the reason for that is because your body just has more time with that HPV to have those cells mutate. I hope that that makes sense. If somebody has not been previously vaccinated, there's FDA approval to have catch-up vaccinations through the age of 26. But there's more and more research showing that um, it could be beneficial up to age 45 to be vaccinated. And then Cervarix is just one that focuses on type 16 and 18. But that's another vaccine that somebody could get. So pelvic inflammatory disease, this is a disease of the pelvic inflammatory tract, and the infection begins in the lower genital tract, so the vagina or cervix, and then the pathogens ascend into that endometrial lining, and then they move all the way into the fallopian tubes and sometimes even the ovaries in the peritoneum, so that lining of the abdominal cavity. So what happens is we have, once again, that inflammation and immune response. So the immune system responds to the invading bacteria, and then that causes inflammation, edema, and pus formation in those affected tissues. In the fallopian tubes, inflammation can cause those tubes to swell, to scar, and to get blocked. The inflamed tissues and all that purulent exudate destroy the cilia. So remember I said we have cilia also in the fallopian tubes that generally move eggs down toward the uterus, but those get destroyed by that inflammation. And then once again, kind of like endometriosis, we have what's called adhesions and scar tissue in the pelvic organs, and that distorts the pelvic anatomy. So once the infection is present, um, it can cause peritonitis, which is an infection of the peritoneal lining, tubo-ovarian abscess, and then something called Fitzhugh-Curtis syndrome, which is actually an inflammation of the liver capsule. So there can be right upper quadrant pain in the abdomen. We have a couple phases of this. We have the acute phase, and then we have the chronic phase. So it's asymptomatic in its early stages. And during the acute phase, somebody gets pretty sick that comes after the asymptomatic period, and they can have pelvic pain, fever, abnormal discharge, and tenderness of the abdomen. So that picture on the right, lower corner, that is a picture of that discharge from the cervix. Should not look like that under normal circumstances, but that is what it looks like with somebody who has pelvic inflammatory disease. Cervical tenderness. So typically, so the cervix itself doesn't have a lot of nerve endings. It's not fun to have a pelvic exam or a PAP, but if the cervix is healthy and there's no infection, it shouldn't be extremely painful. With pelvic inflammatory disease, it is extremely tender, and somebody is very feverish and malaise. So, like almost this flu-like syndrome. Typically, for the diagnostic criteria, we get a good history. Now, what bacteria tend to cause pelvic inflammatory disease? Well, the most common are gonorrhea and chlamydia. So, pelvic inflammatory disease is usually caused by sexually transmitted infection. Not always, really, so this part of the female reproductive tract is sterile. So if any kind of bacteria gets introduced and travels up it can cause this, but really, really, really commonly gonorrhea and chlamydia. So, the chronic phase can look like, um, after the acute phase is treated, that chronic phase can look like infertility, chronic pelvic pain, um, pain with vaginal intercourse, menstrual irregularities, and also ectopic pregnancies can happen. So if you kind of think that through a little bit, it should make sense to you because remember how I said the cilia and the fallopian tubes, it's their job to sweep that egg down to the uterine lining. An ectopic pregnancy occurs when a fertilized egg gets stuck in the fallopian tube and it doesn't implant in the uterus. So if you don't have any cilia to sweep that fertilized egg down, it's really likely that you're going to have an ectopic pregnancy. So, anyway, so the diagnostic criteria for PID, history. So you want to get the symptoms that the woman has been having. You want to ask about sexual history, unprotected sexual encounters, and then a physical examination will reveal the lower abdominal tenderness, the adnexal tenderness, which they're talking about. The cervix and cervical motion tenderness. So, if the practitioner tries to just gently move the cervix, it will be incredibly painful. And lab studies would include blood tests called an ESR or a CRP, which are measurements of inflammation, basically. So those would be elevated. They're not specific to PID, but if someone has all these other symptoms, it's very likely they have PID. And an STD screening. So really important that we screen for those STDs. So I have seen a lot of women in my time as a nurse with pelvic inflammatory disease, both in the acute and chronic phases. And I once worked, I did a lot of my work in the ER, as I think I've shared before. And I worked with a doctor who said, um, in a woman who has her pelvic organs, so her ovaries, her fallopian tubes, and her uterus, if she's febrile and has abdominal pain and you can't find another cause, then you should probably assume that it's pelvic inflammatory disease. But this diagnosis does get missed a lot, and that's really too bad because it can cause some pretty severe chronic problems. So the treatment for PID, number one, you have to treat the acute infection. So a woman's probably going to need some IV antibiotics during the acute phase. It's pretty severe. When somebody's that sick, they usually can't just stay home and take oral antibiotics. But you have to treat um, the STI itself. So treat the gonorrhea and chlamydia. And it's likely that this patient will have to be hospitalized if they're high risk. Also, really important, and I'm not going to get into the nuances of how this goes. Usually, the Department of Health is involved. That when you treat one person with the STI, that ideally their partners should be notified and treated as well, because you don't want a situation where this gets passed along and you don't want this patient with PID to just get reinfected, because that can happen. You can get chlamydia and gonorrhea over and over and over and over and over again. So that is PID. Also, education goes a long way. Educating people about barrier protection, such as condoms, the importance of being screened for STIs before they engage in sexual activity. Another little side note, typically males, when they have STIs, they may not be super symptomatic with gonorrhea or chlamydia, or they may have such low grade symptoms that it's pretty easy for them to brush it off. Um, so, really important that people just get screened, even if they think they're totally fine, before every new partner. So, that's my little soapbox on that. That brings us to the end of our alterations of the female reproductive system. Please reach out to me with any questions and have a great day.